This week's episode is a discussion that's been asked for by members of our WhatsApp community, and it covers how we know whether it's ADHD. Now, specifically, the question focused on bipolar disorder, but we're talking about other mental health disorders and other things that could present as ADHD as well. So we really hope you enjoy this conversation. And as ever, please do consider liking, subscribing, and leaving comments, letting us know what you think about this episode and what you'd like to see us cover in future episodes. Hello, and welcome back to Talk ADHD. We are back for another episode. And this is an episode that really has been requested by the members of our WhatsApp community, which you can find the link to join in the show notes, wherever you watch or listen to this. It's a WhatsApp community of a little under 200 people now, small, compact and bijou. But recently there have been lots of discussions on that group, which I suppose I could summarize when I've read them as, how do I know if this is ADHD? And not something else. Now, we've spoken about this in some terms before, Andrew, in terms of coexisting conditions and in terms of how an assessment works, but I think we'll cover that again. But this is really about things like, and forgive me to anyone listening now if I use the wrong words, language, but this is things about personality disorders. We hear bipolar mentioned an awful lot. We hear psychiatric disorders are spoken about a lot. And it's really the understanding of, from a clinician's point of view and a person living with's point of view, does it make it difficult to understand which we might be presenting with, or for a clinician to see exactly what somebody is presenting with in front of them and what's involved in that? So I think this is going to be a good discussion. I think this will be really interesting. As ever, I'm going to fire questions at Andrew, and I'm going to hopefully give you more direct questions this time, one at a time even, so that you get a chance to answer it point by point. But before the questions, is there anything you want to add to tee up this conversation?
I don't think so. I think it'll take its own natural course. It's a complicated discussion, and it comes loaded with lots of emotion as well for a lot of people. The idea of a diagnosed disorder, for example, is a contentious one at the moment, I think. But hopefully we'll be able to explore some of those ideas.
Yeah, okay. So, first question for me then is, in your experience and having worked in NHS and private and right to choose and through the whole spectrum of practice, how often, how commonplace do you think it is that clinicians are seeing people presenting with what they believe to be AD that could be other?
I think it's increasingly common. As more people become diagnosed with ADHD, it becomes less likely that it's ADHD and that it might be something else. But all through my career in ADHD, I've seen people who are presenting with something that looks like ADHD that isn't.
Is it from a diagnostic point of view, an assessment point of view? Is it as sort of, I don't know, I don't want to say simplistic, but is it as simplistic as, look, if we take a Venn diagram, for example, of bipolar, because that's one we hear on our community a lot, and we put bipolar presentation there and we put ADHD presentation there. Is it the fact that in the middle there is so much intersection that can muddy the waters? And does that then come down to the skill of the person conducting the assessment to be able to see the nuance and the detail?
Yes, absolutely. It's that Venn diagram is almost like overlaid circles sometimes. Bipolar is a particularly tricky one because there is so much common symptomatology between the two diagnoses that the subtleties of description of how those features present is the art of the diagnostic, rather than something as clearly differentiated as, say, ADHD and autism.
And so when I first started researching this and doing work in this field, and still today, I see particularly lots of ladies who will say that they feel they were misdiagnosed with bipolar, for example, before they saw another opinion and were told it was ADHD. Why do you think that is? Is that, again, part of that intersecting circles? And do you think that there's potential that sometimes maybe it's both? Can it be both?
work back through those questions, Andrew. Yes, it can be both, and that creates challenges in the management of treatment. And certainly, I've seen in my own clinical experience people who've been misdiagnosed as bipolar, and it's almost become a cliche, hasn't it? The middle-aged women are saying, "Hey, this isn't bipolar. This is something different." Doesn't make sense. As awareness of ADHD has raised, and I've certainly met women that fit that. So I spent a brief time back in general psychiatry reviewing people in a general outpatient psychiatry clinic for things like bipolar, and I met more than one woman who'd been misdiagnosed. I met another who had been diagnosed bipolar who also had ADHD, but teasing that out and understanding the presentations so that I could confidently say this isn't bipolar or this is bipolar and ADHD, that's tricky.
So for you to say it's tricky as a very experienced clinician, I think it's a point that I just want to lean into here. We're in a world now, this internet, this connected world, where Dr. Google or Dr. AI now even, because it's stepped up a notch now with the sort of rise of AI, right? But Dr. Internet, if we call it that, can provide us with a lot of sort of personal confirmation bias very quickly. We could sit there and think, I think there's something going on, put what we think our presentations or symptoms are into an internet search, and very quickly be very convinced through, have I got type screeners and forums and blogs and everything else, be very convinced that's definitely what I've got, right? That think for me is changing the nature of how people come to decisions about, do I think this is? But from a clinician's point of view, does that changing availability of information, do you think make it harder for you? You know, are we seeing more people coming in kind of, I've got this analogy of clutching pieces of paper going, look, I got this and it must be. Does that make it much harder for you then?
You know, it doesn't, because of the diagnostic process. I think if it wasn't as robust a process, and certainly more of a robust process than people realise, then yes, it could be unsettling as someone making a diagnosis to have people with more of part of the story than they used to have. But actually, those pieces of paper are a starting point. Okay, these are the symptoms that you're describing. And, you know, that's really helpful. But let's not miss out part of the diagnostic process. And as a clinician, I see my job as a guide. I'm not an expert on each individual that I meet. I've got experience of meeting a range of individuals, and I use that to inform my practice with each new person. And every new person I see starts with a clean slate. So if they come with clutching a load of evidence that says I fit this, then that's a start point. You know, okay, maybe you do. Let's explore that. Let's look at that in a bit more detail. Let's look deeper into the diagnostic criteria. I think it's easy to get lost in those sort of the headline symptoms of diagnoses, and lose the subtlety of the criteria lower down the list, which are often the ones that really do filter out misdiagnosis. Yes, you can present with the whole range of 18 ADHD symptoms, and not have ADHD.
This might be a really controversial question, but hey, I suppose I've got a reputation for asking controversial questions. I was seeing on LinkedIn a few weeks ago now a discussion that got quite heated, kind of in this sphere, about the duration of assessments and diagnostic appointments, and whether the fact that there was such a variance. And I was seeing times from people saying my whole diagnostic appointment from start to finish was 45 minutes, to people saying, well, mine was multiple hours, between 2, 3 and plus hours, right? And it was kind of like a my dad's bigger than your dad conversation by the end of it. It was my clinician's better than your clinician, and my assessment was better than your assessment. Actually, though, it did raise a question for me, which is there a risk that if we are in a time pressured assessment, and we know there are those services where they're seeing more people a day than perhaps others, right? Because of pressures. Is there a risk that no matter how rigorous the criteria and the assessment processes are, that a misdiagnosis, that there's more risk of a misdiagnosis, I suppose is what I'm saying.
Of course there is. Of course there is. To extend the controversy, I had a 45-minute diagnostic assessment, and it felt like speed dating. I know the process. I know the journey that a diagnosing clinician goes on. And it would have been very easy, given how it was like rapid fire questions, but really important questions. And there wasn't time to discuss it. It was just sort of very short answers. I was diagnosed by a clinician that I respect and that I have a lot of time for. I chose her, in fact. And I know that had I not been aware of the diagnostic process, I could have skimmed over things and played down things that could have confounded the diagnosis, because there just wasn't time to discuss the subtlety of things. So it was very headline, symptoms oriented. Yes, there was some exploration of impairment, but not in the level that a longer assessment allows. And a longer assessment also allows setting some context for the diagnosis if it's being made. So it's possible. I've said it on this podcast before. It is possible to whiz through a series of quite closed questions and arrive at so long as the person's given honest answers, a reasonably robust diagnosis. Yes, you meet those criteria based on your answers to these however many questions. It would probably be possible to write a computer program with an algorithm that takes people through, and so long as they answer honestly, come to a reasonably clear diagnosis. But that then undermines the meaning of that. And I think also the subtleties of things like coexisting conditions, particularly bipolar disorder, it would be tricky to write the differentiators into the algorithm that would say, yes, that is bipolar and ADHD, just bipolar, just ADHD. There's something that comes from discussion and clinical impression that you can't build into an algorithm. And nor can you build into a 45-minute assessment, because there's so much information has to be taken, so much descriptive information.
Going off that then, is there potential, a risk even, that if we've been through a quicker process that didn't have the time and the ability to be as detailed and as nuanced as perhaps a longer one might, that a pre-existing other mental health condition, whether it be a psychological disorder or bipolar, that may then present itself as we go through titration, because we are titrating for the symptoms and the presentation of ADHD that have been identified. But might it be that, wait a minute, the meds don't seem to be doing what we thought they would do, and the information the patient's giving isn't quite what the clinician, it doesn't match up? Could that be the case then, that suddenly we go, do we need to look in another direction here?
Yes, absolutely. And that is a very important part of what titration is. It is monitoring for that and making sure that those early warning signs that other things aren't happening. That's what we were saying last week about the importance of communication in a titration process, because there are subtle early warning signs that the medication dose is too high, or it's the wrong medication and it is exacerbating something else that's going on. And that's very much what titration is about. It's not just find the right dose and make it work. It's make sure that it's the right dose of the right medicine for the correct diagnosis. It's misdiagnosis it's almost inherent in the process of making a diagnosis, that at times things will be misunderstood. It happens a lot with ADHD. We've talked about bipolar diagnoses being made for people that don't have bipolar, they have ADHD. It's just an ordinary part of the classification of these clusters of symptoms, that sometimes the person making those classifications will get it wrong. No matter how good they are, no matter how detailed their assessment is, sometimes it's still not enough to capture everything that's going on. There are always curveballs, because we work with individuals. So it's not possible to, as someone who diagnoses conditions, to say I always make the right diagnosis. You make the diagnosis that you can around the criteria that you've got with the information that you have available.
Do you think that's also part of this ongoing conversation that I'm seeing recently about how our understanding of what ADHD is, and particularly in terms of causality and whether there's environmental effects and whether there's sort of effects in terms of toxins and all sorts of other things that we're hearing? Do you think that's why that's an important conversation at the moment? Yes, we've got these 18 criteria to meet, but there's so much that could make us present those symptoms.
It's an interesting part of the debate, this, because yes, that's important, and the evolution of the science is important, but the science is still the science, and the criteria are still the criteria. So I've heard it said that, that ADHD is not a disorder. Don't call it a disorder. If we do that, we have to throw away all of the understanding that we've developed. We have to redo all the clinical trials. Even just changing the name of ADHD would mean going back to the drawing board on everything. So, I'm diagnosed with ADHD. I don't like to think of it as a disorder. I don't like the concept of disability, but that's my shit to own. The science has got us to a point where this thing that we are calling ADHD, that has these criteria to it, has this range of options available to us. And I think to deconstruct those 4 letters, and I often do flippantly, it isn't an attention deficit, it's an abundance of attention, it's a dysregulation. All of those debates are healthy, but they are not, in my opinion, mutually exclusive of also that medical model understanding of ADHD as a diagnosis of a mental disorder. If you're offended by the concept of it being a mental disorder, then we need to go into the whole history of psychiatry and what it means to medicalize mental disorder and read Foucault and those sorts of things. It's a done debate. It was done in the 1970s, the anti-psychiatry movement. And it was looking like, yeah, that's great. We are asserting ourselves as a phenomenological entity rather than being reduced into these criteria. But it is something we need to do because humans are complex. So the classification of mental disorder is a really useful tool. It's been proven time and time again. It's the foundation of mental health care is the classification of these difficulties. So to say that is a completely useless system and it undermines the wonderful diversity we have in society, no, it doesn't. It's possible to have more than one model operating in a system, and I think that is the way forward. Neurodiversity as a concept is really important. Does it mean we need a full paradigm shift? I know there are those out there that are arguing for that, but a full paradigm shift means we walk away from all that medical model understanding. We say that medicines need to be re-explored and need to be the science redone. So the whole understanding of the diagnosis is founded on this medical model.
Whilst Talk ADHD is not sponsored, we are proudly in partnership with Divergence UK. Divergence is a service staffed by people living with ADHD that evolved out of the experience of them working in services not run by people with ADHD. They know what works. They understand what barriers some people face with other services, and they're constantly exploring how to do things differently so that the service works for the people using it. They did a public consultation before they launched, and they've stayed faithful to what people told them a good service would be like based on their experiences. If you are looking into whether you have ADHD or a coexisting condition, I genuinely would recommend contacting Divergence today. Yeah, it is. And I'm non-clinical, as everyone knows, never have been, never will be. And yet I think I'm one of the few people who I've never had a problem with the term disorder in terms of ADHD. Because the way I define it for me is I can categorically say there are times where my ability to do the same things as other people has been disordered. Whether it's my ability to carry out executive functioning tasks, whether it's my emotional capacity or regulation. Yes, there are times where that is, when not treated, when not supported, whatever that looks like, that is disordered, right? And that's the only way I look at it. There are times where I am, there are times where I'm not. Now, I understand how some people are really loudly and proud of, it's not a disorder and we should change the name. But I think you're right. That does just do away with everything that we've got to get us to this point, and raises some very, very challenging questions. And what I was just thinking as you were saying that is, it kind of runs in tandem, doesn't it? We hear lots of arguments at the moment around ADHD. It's been overdiagnosed. Everyone thinks they've got it now. Why are so many people getting a diagnosis of ADHD, right? Is it actually just a feature of the 21st century world and the 20th century world that more people struggle to concentrate, are inattentive, are impulsive? Is it a feature of other things? And I think if we were to just throw out everything that's got us to this point, it would be nigh on impossible to answer those questions, and it would make a fundamental error for me in what support may look like. Again, it's the argument of, it's just a big pharma. It was created by a big pharma. I've seen that 3 times this week. 3 times. People saying it's just a big pharma invented thing. It doesn't exist. It's just so they can sell their pills. I'm really sorry. As I sit here, having taken my Elvans today, I can categorically say I'm able to concentrate better, function better, listen better, and manage myself better. So I cannot for a second compute how that means ADHD is a made up thing to sell me that pill. I chose to go to a specialist. I chose to say my life is in such disarray and is such a shit show that I've just had a full scale nervous breakdown, that I'm suicidal, that I can't cope with failing anymore. Help. And that helped. To say that that's some Machiavellian plan baffles me, but I see that frequently. And I think this is a sort of a bit of a right angle in this conversation here. That as a frame, saying it's not a disorder as a framework, and conversations I'm seeing a lot recently about, well, it's not just what we think. And actually, it's, again, we're going down the routes of people who go, it's all trauma. It's a trauma-based thing, and treat the trauma, the ADHD goes away. Whilst I don't disagree that the majority of people I've met, worked with, supported, who have ADHD have experienced in their way, and I think trauma is where it gets tricky, anything on a scale from very difficult circumstances to real trauma, so real deep-seated trauma. Whilst I see that frequently, I get very challenged by people saying, treat that, there's no ADHD, there's no need for medication. I don't see that. Right. But with all of those conversations, it kind of brings us back to how challenging it is for people to actually know what ADHD means, what it could look like in terms of something else. And it makes it challenging for the clinicians to unpick that, because there is just that volume of opinion and information and things being presented as scientific, clinical fact that at this point, I'm not seeing verified, right? Now, it's just me, and I try and verify everything. That's the way I am. But do you think that's muddying the waters as well? That there is this shift in, this is my opinion, and I'm going to shout about it, and I'm going to completely deny that there is an opposite side to it or an alternate view, because it doesn't fit my narrative at this point.
It's not about this person can be caricatured in these diagnostic criteria. That's not what a diagnosis is for. It's not what the label is about. And that doesn't in any way invalidate the fact that, growing up with undiagnosed ADHD is challenging. It is traumatic to think you're different but not know why. It is normal for someone diagnosed as an adult with ADHD to have stories from their school years that are, that you could almost put them as a diagnostic criteria. They're so common. These experiences in puberty that the adults being diagnosed with ADHD describe, and it's traumatic. It's challenging to go into secondary school and suddenly be overwhelmed by the challenges of that change of environment and not be able to busk it through any longer, and be met with challenges that your brain just can't process because it has ADHD, but no one's ever defined it as that. And in terms of trauma as well, bad stuff happens to people who live with ADHD, just like it happens to other people. And I think a child born into a family with ADHD is born usually to a parent with ADHD. That increases the risks of bad stuff happening. It doesn't mean that there's going to be bad stuff happen, but that child is born with differences in their brain. We see that genetic heritability. We haven't fully defined it yet, but it's there. We know it's there. That hasn't been created by trauma. So to say ADHD is a trauma response, no. You can have a trauma response alongside ADHD, so much so that I think it's probably more common you do than you don't. But that doesn't mean that ADHD doesn't exist in the way it's classified in the diagnostic criteria. But ADHD doesn't happen in isolation, and it's rare that you don't have coexisting conditions alongside ADHD. So, yeah, it's easy to retrofit this idea that trauma is causative of symptoms of ADHD, and hell, it is. You know, it's actually a differential diagnosis. This idea of childhood trauma can actually lead to symptoms that look like ADHD in adulthood. Yes, that is true. But that doesn't mean that there are not people out there who have had no trauma in their life who still meet the criteria for a diagnosis of ADHD. So it's a very nuanced argument, but it boils down to people's biases, I think, and the models by which they approach this, and the ability to take on different perspectives, to accept that there is a social model of disability, there is a medical model that describes disorder, there are psychological models, and they're all useful and they're all valid.
Yeah, I think all of that, I hear that and it makes sense. I think there's something in what you just said that really struck me, though, is it feels like at the moment to me that we're losing the ability to almost respect anyone else having an alternate perspective. And that there's if it's a model, there seems to be an approach of, if I just keep saying the same things, it will become fact. If I keep saying that doesn't exist, that you're not right, that becomes fact. And I think that's causing confusion. When I'm not consulting and trying to help organizations understand how to support people, fundamentally change the way I do that this year as well, interestingly, through doing this podcast. But when I'm not doing that and I'm mentoring people, time and time and time again, what I'm trying to say is, okay, whatever the information is that's brought you to this point of, do I need a diagnosis, or even I've just had a diagnosis, now is the time to focus on, what does this mean to you? Not what has someone else told you it should mean to you, right? Because that's where it gets confusing. That's where it gets dangerous. And I'm wondering, we are talking about the conversation about ADHD, but I'm wondering if those people who do live with bipolar disorder, for example, would say the same thing about the conversations in the communities around that. I wonder if is this a phenomena of the modern world that people are so keen to show their knowledge that sometimes we lose the humility to step back and go, is that actually all I know? I mean, there were two concepts on something I saw only this morning, which sort of now go, there's a bit of this. There's the Dunning-Kruger effect, right? This thing of thinking I know more about everything than I do, kind of distilled down. And then positive illusory bias, which we are told is a very common, particularly in young children, particularly in boys, a very common ADHD presentation of, I just perceive I'm better at everything than everyone else. I've just got this inflated sense of ability. And I'm seeing what feels like a lot of that at the moment. A lot of those things played out by people telling others very confidently what these things mean, to the point of them questioning what a clinician has said when we're not clinicians, and to a point of questioning a diagnosis and questioning whether people should be given medication. And I think there's something really, really scary about that for me, right? There is something that makes me really worried about that. You know, the topic I think that this brings up for me in all of this, particularly around ADHD and treating, is I keep coming back to medication. We still have two very distinct camps. If you look at it, we have those who are willing to try medication, are willing to say, well, this might help, right? And are willing to go into it very open-mindedly. And those who are very much, no, it's big pharma. You don't need medication. That's you're just been sold that for profit. And actually, you can manage your ADHD symptoms completely holistically. You don't need any medication. And you know, and particularly when we talk about children as well. Oh, children are being over medicated, and pills are just being pushed down their throats, and they don't need. That just makes no sense to me. It makes no sense again because the arguments that I'm seeing are about, well, we haven't got any research into the long-term effects of medication on children. Well, we do. There are ongoing studies into the long-term effects of medication and the effects of children taking stimulant and non-stimulant medication. Right? That research is continuing daily. But the argument is, oh, well, we don't know what the effects will be. Well, the only way we know is by people who believe that that's relevant for their children, trusting a clinician, right, to say this may help and being invited into that discourse. But when we then look at teenage years, for example, when the hormones start surging, I'm now wondering, is that a point where this intersection between whether they're psychological presentations or other disorders like bipolar or other personality disorders can start to become even more prevalent, and we start to see the struggles that children have been suppressing when they were younger play out? And is that why we see so many conversations about I was misdiagnosed in my teenage years, in my early years? Because actually we're in a phase where we don't know ourselves, we're struggling to find our place, we don't know what fitting in even looks like, and we're not sure why. And we haven't had that care time luxury even of seeing a medical clinical professional who says, actually, I think this could be what's going on. I don't know whether that's a big part of this conversation as well. And I guess it's all wrapped up in, I worry about how much I'm seeing clinicians not being trusted, that it all seems like every clinician is underhand and they're just pushing an agenda. That baffles me. And I don't know about you as a clinician, but do you see that conversation out there, and do you think that is part of the issue?
Certainly I see that trajectory that you've described, because growing up with ADHD is stressful. And that's why we see the emergence of anxiety, low mood in teenage years. That's happening. And that's quite understandable. And I think from experience, what then happens if you continue to push and drive into that stress, it can lead to things like bipolar developing. Running alongside that, the development of the personality is something that's very much happening in childhood. It is the personality is an adaptive response to the circumstances in which that personality is evolving. So if those circumstances are adverse, not necessarily traumatic, but adverse, then that is going to have an impact on how that personality evolves and that person develops an understanding of how to interface with the world. So coexisting conditions, so it's not groundbreaking news to say that's the norm. And I think that the complexity of that is what's confounding people's understanding. That they say a lot of what is actually a coexisting condition is a feature of ADHD, because that's people's experience of living with the diagnosis of ADHD. But that is not the diagnosis of ADHD. The diagnosis of ADHD is very much around those core symptoms and the structures in the brain that manage those core symptoms. It's not about that person's response to how that biology, chemistry works or doesn't work in their day-to-day life. And that's why we need these multiple models back, because it's not helpful to just see the personal experience from a dopamine deficiency in the prefrontal cortex. And I intentionally used a phrase there that we've deconstructed and criticized in the past, because you can't have these conversations without saying conflicting stuff. And if you're trying to have this kind of conversation in a nice, clean, tidy way, it's never going to work. And I think that's potentially where a lot of the tensions that you're describing come from, the frustrations of hearing people say ADHD is a trauma response, or it's not a disorder. All of these, they're not seeing the nuances and the subtlety of the complexity that we need to approach the human experience with. That yes, having trauma-informed ADHD care is a really valid approach to treating ADHD care, but it's not a comprehensive approach. So we need to take these multiple perspectives. I'm aware we haven't really talked much about bipolar. I mean, we've
Yeah, funny enough, I was just looking at some of our comments on the chat, and I was going to dive into that. I think let's do this then. Describe bipolar. Just tell us what is a presentation of bipolar and kind of what's the symptomology of it, I suppose.
Okay, so I'm going to do that in a provocative way.
That's unlike you.
Because I need to. So bipolar, as the name suggests, is a disorder of variance of mood. There are periods of low mood and at least one period of elevated mood, mania,
Right.
or hypomania. So there has to be that variance in mood, and there are different intensities of that. So that it can be quite a rapid cycling thing that's not very intense, which we would refer to as something called cyclothymia, which is just the cycles of mood. That it's a little bit outside the normal range. That then becomes a bit more intense, and that's where we move to bipolar type 2, which requires that there has been periods of hypomania, which is just under mania, hypomania, below mania, and depressive episodes as well. And then bipolar 1 is the more intense manic episodes that are clearly there. So that has its own spectrum. Bipolar has its own spectrum. But what can that look like? That can look like someone who's overactive, someone who, features of depression. You can be forgetful, you can lose things, you can struggle to concentrate on things, get quite distressed, you can get quite dysregulated. What else is there? In a hypomanic episode, talk a lot, be very loud. You see what I'm saying here?
Yeah.
It does. That's exactly what's going on here. It's lots of babies getting thrown out with lots of bathwater. So the diagnostic criteria don't define what it is to have any condition. Now that's not what a diagnosis does. A diagnosis has a set of criteria, indicators that something's going on, and indicators that it's not that. That's a description in there, and that sort of classifies that presentation into that cluster, which then meets the diagnostic criteria. The big one that stands out, and I totally agree with this, the idea that emotional dysregulation isn't included in the diagnostic criteria for ADHD. It's quite a well talked about issue, and there is absolutely no doubt in my mind, as someone living with ADHD, who loves people who have ADHD, who works day in day out with people who have ADHD, that there is a feature of emotional dysregulation in this thing that we call ADHD. It's there. However, if you put that in the diagnostic criteria, in my opinion, muddies the waters no end, because there are so many different conditions that have emotional dysregulation as a feature of that. So it's not a useful diagnostic tool to tease out. If you're emotionally regulated, you can't possibly have ADHD, for example. It's not possible to say that. It's not a useful lens through which to observe ADHD and say that is ADHD, that is not, because so many other things can lead to emotional dysregulation. But that doesn't mean I don't think it's a feature of ADHD. It's just not a feature of ADHD that is helpful in differentiating ADHD from other things. So that comes back, that sort of dials it back to what's the meaning of a diagnosis. A diagnosis isn't a comprehensive description of who you are. We've said many times, you are not ADHD. You are a person living with this condition that is described as ADHD. And I think people that want to throw away the medical model think that somehow the medical model claims ownership of rights to describe what it is to have a condition. And that's not what's happening. What's happening is the medical model classifies presentations so that, and sorts things so that information can then be used from research findings. People that meet this criteria respond well to this particular intervention. Yeah, that's what a diagnosis is about. I'm describing ADHD, yeah?
Yeah.
I did that on purpose.
It all could be okay. So, $1 million question then.
And
how do you know?
Go on then.
How do you know whether it's
How do you know?
bipolar type 2 presentation, or how do you know that it's ADHD?
Because there are subtle differentiators, but actually they're not that subtle. Bipolar is an episodic thing, so it happens in bursts.
Right.
Yeah? So there are cycles of low mood, there are cycles of mania. It's not a pervasive and persistent presentation.
Right. So there's a distinction straight away.
So that's one differentiator straight away.
Yeah.
If you are cycling through different presentations in terms of mood, it might steer you more towards bipolar. But if there is that consistent, persistent and pervasive presentation of those symptoms that I've just described, that might steer you more towards ADHD. The key one for me is sleep. So when I'm differentiating ADHD from bipolar, I do a lot of talking about sleep, because a manic episode and a hypomanic episode is very different than the sleeplessness that someone with ADHD describes.
So?
And you know the frustration of not being able to get to sleep because of your ADHD? I know you know that, and I know you know that I know that as well.
Yeah.
We've talked about it in the past, yeah?
Yeah.
In a manic episode, that is not going to happen. It's exciting to be awake all night because all those wonderful opportunities are finally there, and it's brilliant. And I don't need sleep if I'm having a hypomanic episode. So if you're sleepless and you're desperately trying and wishing you could be asleep, it's more likely ADHD than bipolar. I think a lot of the misdiagnoses of bipolar come from the idea that, yes, they've been awake all night, and that is clear indication of a manic episode, and it isn't necessarily indicative of a manic episode. It depends on what was happening when they were awake all night.
Folks, it's Matt, sorry to butt in, but please, would you do us a favour? We're a year old now, and we're really grateful for everyone that's been with us in this year, learning from us and sharing the information that Andrew and I have put out. But we need your help. So could you please like, share and subscribe to the podcast and to the channel? We have big plans for 2025, and we need as many people to be able to see what we're doing. So if you can do those things for us and leave comments wherever you watch or listen, it really, really does help. For now, let's get back to the conversation. Okay, so here's a question then. And forgive me, my eyes were looking because I was looking at part of our WhatsApp chat. I just read a statement from someone that I've heard so many times before, and now I'm wondering if that's what it is. It's nuance. What they were saying was, I can't understand how for so long so many psychiatrists said it was bipolar when actually it was ADHD. Now, I don't know the timeline in that specific individual's case. I don't know how long a period that's over. But could it be because of the changing understanding of the presentation of ADHD and those subtle / not so subtle differences between ADHD and a bipolar episodic presentation that mean for so long it wasn't through malpractice, for example, that it wasn't picked up? It wouldn't have registered that could be ADHD.
Yep. It's exactly what it is, Matt. You know, if you were diagnosed bipolar before around about 2015 outside of London, and you think it might have been a misdiagnosis and it's ADHD, it's probably more likely that that's the case than afterwards, because there is a change in the understanding of the presentation. So before 2015, I saw people with ADHD. I didn't have a clue what ADHD was. I wasn't taught about it at university. It wasn't something that we talked about in clinical supervision until I specialised in it. I didn't know. So you don't know what you don't know. It's your Dunning-Kruger rears its head again, because, hey, doesn't the description of ADHD really fit with bipolar? Well, if you're looking for bipolar, but you're not looking for ADHD, you're not going to have that conversation about the nature of the sleeplessness that sleepless night. You're going to say that was a sleepless night, tick in the box for a diagnosis of bipolar.
Right. Leads me to another
So
comment I've
it
seen a
wasn't a
lot.
malicious thing to make that diagnosis.
No, yeah, no, and that's the bit I've always thought. I can't believe doctors are doing, or clinicians are doing this through malintent. It's just because they didn't know what they didn't know. What's the normal treatment for someone with bipolar? And forgive me, I don't know the answer to this. I don't know whether it's medication or whether it's therapy or a combination, but how do we normally treat someone with bipolar?
So again, it's the mainstay is medication, and it is a long-term condition. Therefore, it, just like ADHD, it's a matter of pills and skills, and there are a range of pharmacological approaches to it. The mainstay, what used to be called mood stabilizers, now called anti-manic drugs, that are also used in epilepsy.
Okay.
That's how they work. They're very good at stabilizing things, taking the agitation out of the mania, but also helping reduce the lows of that cycling of mood, so it just slows the rhythm of the cycle down. So that's one way to go, but hey, there's another way, and that's using dopamine theory. And in that case, there are a range of antipsychotics that are licensed to treat to treat bipolar affective disorder. So you can use these anti-epileptic, mood stabilizer, anti-manic drugs. There is very good evidence around the use of lithium, which has its own sort of contentious history because it's a difficult drug to manage. It's a drug that's prescribed under shared care, interestingly enough. And then there are the antipsychotics, which are used to stabilize the dysregulation of dopamine.
So the reason I asked that is I'm just wondering now whether there's been historic cases of somebody who's being seen by a clinician and then it looks like bipolar because we don't know what we don't know, and yet those treatments just don't seem to work. They don't stabilize the person, they don't control it. Could that then be where we suddenly get to, wait a minute, if everything we're trying isn't working here, are we looking in the wrong direction?
It's a bit more nuanced than that because often there is a positive response to it.
Right.
I lay the breadcrumbs of clues there for you, Matt, and you didn't follow the breadcrumbs of clues. The antipsychotics are dopamine
Stimulants.
blockers. Yeah. So they block the dopamine transmission. If you give someone who's diagnosed bipolar but isn't actually bipolar, they have ADHD, these dopamine blockers. You're going to see a change in their ADHD symptoms because we're changing the regulation of the dopamine. Yeah. So there's that feature. But often that's not the first port of call. The first port of call in treating bipolar is usually one of these anti-manic agents. And so something like lamotrigine. It used to be sodium valproate until we realized how harmful that was to reproduction. But now it's more lamotrigine. Now, lamotrigine is great for sustaining mood, for regulating that agitated feeling that comes in life, not just as a result of bipolar, but in life. It takes away that prickly, agitated feeling. And if you're misdiagnosed with bipolar when you have ADHD, lamotrigine can help. So we would say that's a partial response to this bipolar treatment rather than a human response to the modulating action of lamotrigine on that agitation. So we would say partially responsive to treatment, and maybe give an antidepressant as well. So it gets, you can go down blind alleys like that and get stuck on a partial response to a treatment for a condition that you don't have. And I've definitely met people in those circumstances.
What if it's both?
Okay.
How do you get to the point where you know it's both? Given what you've just said.
Age of onset is a key one. You don't see many bipolar primary school kids, yeah? So it's possible to look through the developmental history, see those signs of ADHD, but as the strain and the challenges of growing up with ADHD steer you into disorder in the realm of dysregulated mood, that then meets the criteria for bipolar, you've got that combo. And it's then diagnostically a case of teasing out, can all of these inattentive, hyperactive symptoms be explained within the context of this diagnosis of bipolar? If no, then it's ADHD plus bipolar. If yes, then it's just bipolar.
Forgive me, lay comment now. I'm going to assume that would then make the ongoing care and treatment of an individual with both more complicated. Because whilst you say that the dopamine blockers could work, I'm wondering where that would go for someone.
Yeah, but it's a logical sequence, isn't it? If the bipolar treatment is stabilized and we're seeing that regulation of mood, but we're still seeing ADHD symptoms because there is ADHD alongside it, so long as the stabilizing effect of the treatment for bipolar is there, it's relatively safe to then add in the intensification of dopamine and noradrenaline transmission overlaid onto that. You have to be careful. You can't just whack up great big doses and flood the brain with dopamine, because that could precipitate a manic episode. And there is a risk of precipitating the manic episode. However, if the anti-manic agent is effective, then that's already covered. So someone diagnosed bipolar but not taking medication coming to an ADHD clinic should ring alarm bells for the assessing clinician that's diagnosing ADHD, because there is that risk of precipitating a manic episode, which is an enormously disruptive experience for someone's life and can cost them years of their lives.
I have another question. This may be completely impossible, but I'm just wondering, would it be possible ever for someone to receive a diagnosis of ADHD, to be treated for a number of years with ADHD? They're on stimulant meds, but they're treated. And then because circumstance, for bipolar to start presenting, could that happen? And I'm presuming the answer is yes. Okay, right. So hold that thought. So let's say that happens. I'm just running through a scenario here. And I'm now thinking in the realms of, we've spoken about university students a lot in the past, and about how typically the first time we really see that it's ADHD is university, when all the scaffolding's removed. Yes. And then somebody gets through their university sort of tenure, and hopefully maybe, they come out of it going, well, I knew this was ADHD. If that experience was so traumatic, I'm wondering, let's say they were at university in Birmingham, where I live, right? And they've received their ADHD diagnosis while at uni. And then they finish uni and they move home to Glasgow, for argument's sake. And then because of the stress of trying to find a job and what do I do next, and because of life, bipolar then starts to present. If they'd managed to be on shared care while they were at uni, and then they move home and they move back to their family GP, for argument's sake, and a GP starts going, wait a minute, yes, I see an ADHD diagnosis and shared care was approved, but now I'm concerned that there is other. Would there ever be a potential that GP might say, hold on, I need to talk to your ADHD clinician about this, because now I need to check whether this is okay. I need to check what's safe to do. Because to me, that's my understanding of a shared care agreement anyway. It's not just dispense pills. Is it safe to treat this person for this? So is that a scenario that could, in theory, happen?
Worse than that, Matt, it should bloody happen, and it's not happening enough, because we can just blindly go, oh, well, we've got shared care, we'll just carry on. So I had a patient years ago. Let's not forget that ADHD is a neurodevelopmental condition.
Yeah.
So I had someone that I worked with early on in my ADHD career who was on an annual review. He was 23. Saw him one annual review, absolutely fine. The methylphenidate preparation he was taking was working really well for his attention. A year later, he came back and his medication was precipitating psychotic features. He was in trouble with the police for stalking. No one thought to get in touch with the ADHD team and say, this is strange, he's not acting like he usually would. Within a couple of weeks of stopping the medication, that resolved. His brain had developed such that the inattentive symptoms were below diagnostic threshold. His ADHD had improved to a level that actually the ADHD medication was precipitating problems for him. And these are the things that can happen because brains change, young brains in particular. So this is why we often see these issues in people in their early 20s, is because there's so much going on psychologically, socially, personally, biologically. So it's a huge risk time. And I think the GP who says, I'm not comfortable with this, I want you to stop this medication until we get this reviewed, because I'm seeing changes in mood, because I'm seeing unusual, uncharacteristic stuff happening that might be changes in your personality. There are so many things going on that it would be reckless to continue treatment without getting some specialist support.
Of interest, and only as a touch point, if, for argument's sake, we've got that scenario and a GP, I presume, emails, writes, whatever we do to whoever the diagnosis came through, and they just don't get a response, or they don't get the response that they makes them comfortable, are they within their clinical rights to then say, I'm not going to honour the shared care for your ADHD medication because I
They have a
can't
duty
guarantee?
They have a duty to. It's not they're within their rights. They have a duty to.
Okay,
Yeah,
right.
sharing care is about a working relationship. It's not about a baton passing exercise as to who's going to sign the prescription. It's about owning all of these risks and working together to have these responsibilities.
Into that deeper, but yeah.
We do, yeah.
I just think the reason I asked that is because, again, a lot of the times when I see these conversations about I was misdiagnosed, forgive me, it's of people who were misdiagnosed with bipolar in their early to mid, even to late 20s, right? When, as you've just said, for ladies, particularly with hormonal changes, there's a lot going on. I mean, there's an awful lot that can be affecting things. There's an awful lot that can be causing presentations of different things. And then when we see them get to these and things perhaps stabilize and change again hormonally, that's when it's, well, actually, this looks like it was actually ADHD all along. And I'm now wondering if that is more common than not because of that, because that period of life is so huge, as you said, in every facet, psychologically, biologically. Does that make sense?
It makes total sense. So it is possible with a moderate impairment from ADHD to get by without medication for ADHD. It's tiring, but you can do it. It's why we see so many 12-year-olds who are going into year 7 suddenly it looks like ADHD, because the environment changes and that precipitates more of the impairment. And that's true if you're 70, you've just retired and you've just been full on leaning into life and living at a hyperactive pace, and then all of a sudden you retire and you're sitting staring at the wall and not realizing that that's happening, zoning out. That was ADHD all along, but you've learned to live around it. You've adapted to it, and that's a very skillful thing to have done. Would life have been different with treatment for ADHD? Potentially, it might have been less challenging to develop those skills with a medication for ADHD alongside putting all of that effort into place.
No.
So
I completely hear that.
ADHD doesn't happen in a vacuum. Neither does bipolar disorder. Neither does a personality disorder. This is all happening in this unit that we call a human being that has relationships with other human beings. So teasing apart which symptoms belong under which banner does have limited use in defining who we are as a person, but it's very, very useful in defining what's going to work and where the risks are.
Yeah, I get that. So I want to kind of wrap this up. There's a question in my mind here. We've discussed on this podcast how long potentially NHS waiting lists could be, 12 to 15 years if we do the real maths and sort of drill into it, right? I don't know what the stats are for diagnosis of things like BPD and personality disorders. We can look into that. But my question really is this. Going back to what we said earlier on about we're in a world now where I could ask ChatGPT a question, for example, say, I experience this on a daily basis, right? What might that be? And based on all that AI and machine learn, it could come back with a number of things. Now, let's say it comes back with a result of this could be ADHD, right? What's your opinion on people then sort of, if they can't get a diagnosis, can't afford, it's too long, whatever it may be, what's your opinion on them trying to implement then strategies and tools, non-pharmacological tools that they see to try and help them? Do you think that's a sensible approach?
Yeah, of course it is. Of course it is. Just because executive dysfunction is front and center in the diagnosis of ADHD doesn't mean that it isn't a feature of bipolar affective disorder. Therefore, if you are using strategies and behavioral techniques, I always struggle to find my car key, so have a car key hook. It doesn't matter whether you're bipolar or ADHD, the car key hook will work so long as you use it. So I'm all for pre-diagnostic skills training programs. I think that's a really good idea and a way of dealing with lots of people on a waiting list that can help prepare people for what diagnosis and treatment for ADHD can bring, and actually improve outcomes by helping people understand that there are things that can be done other than medication that can make a big difference. A lot of what I'm doing in my diagnostic work is teasing away the wonderful efforts people have made to adapt to the difficulties they have as a result of their ADHD, so that I can see beyond the coping strategies that are often amazing and see into the struggle that is the exhaustion of having to implement all of this just to keep going.
Yeah, I
So
completely with
I'm
you there.
absolutely an advocate for any skills training, any psychoeducative stuff around managing inattention, managing hyperactivity, managing impulsivity. Medications where it's ADHD are such a helpful tool that it would be sad not to at least have a go, so that you know what it is that you're saying no to.
To explore.
That's the wonder of ADHD treatments. It's not like having surgery or even making the commitment to a few months of an antidepressant to see if that lifts your mood. That first dose of a stimulant medication will have an impact on your ADHD, if that's what it is.
Yeah, it will. Okay. So I'm just trying to wrap this up in my head. Hopefully, and I've a feeling we could go back to this and back to this and back to this, but hopefully what you've gained listening to this conversation is more insight into when we see these headlines and when people experience being misdiagnosed with things, that there are always reasons behind that misdiagnosis. It's not about incapability or willful mispractice or anything. It's a feature of what's been presented at the time and then what may be presented at a different space. It's remembering for me that an assessment is a full stop at that point in time. Whilst we may have struggled with things all our life up to that point, the day we have that assessment, the day we fill in our paperwork, etc., is a mark in time. And therefore, it's conceivable that 3 weeks later or 6 weeks later, we may feel and present very differently, and that it could then point to something else. So it's important that we remember that misdiagnosis can happen, but that it's not a feature of negligence. It's a feature of people are complicated. We are complicated beings, and there are structures in place. That said, it's not to negate the challenges of somebody who's been misdiagnosed either, of somebody who's had to come later in life to the realization that it was ADHD all along, for example. That's difficult, and we know that leads to the same kind of grief process that we've discussed in previous episodes. What I hope, though, that you've got from this is more insight into why a good assessment, why a good relationship with a clinician is so important, and to kind of go back to the last few weeks' episodes, why being asked lots of questions that you may feel sometimes are just irrelevant or repetitive is so important. Whether it's at assessment stage, whether it's at diagnosis stage, and particularly in titration, constant questioning and constant sharing of information. What I take from this discussion is without that can cause issues. That can mean things could be not deliberately missed. And so the ability to share, the ability to not just think about what do I think this for example, medication is doing, but what isn't it doing that I expected it to do? And to talk about sleep and to talk about mood and to talk about regularity is so crucial, because that points us to further information and potentially other information about ourselves. And ultimately, we start a process of asking for help because that's what we need. Help. It's not that stops because we've been diagnosed. In fact, it's the start of another process of finding new information about ourselves, and that should continue. So I think that's what I would like to say. Andrew, anything for you that you would like to close this off with?
I think let's not throw the diagnostic baby out with the bathwater. It has a function, and that doesn't need to undermine a neurodiversity paradigm at all. In fact, it can be used to define it, and help us access the help that we need, and help us evolve the understanding and the science that is the foundations that are there already. Let's not just say that's all wrong because I'm offended by a word. Yeah, some of those words carry historical baggage with them, and that's unpleasant, but that's what we're stuck with because that's where the science has got us to. But it doesn't mean we should just walk away from it because a word is offensive.
Agree. And listen, to everyone who's listening or watching this, just to echo what Andrew said, if you would like episodes that particularly look at certain things like Andrew's just mentioned, whether it's a specific bipolar episode or personality disorders, please let us know. The only way we know what you want us to make a podcast on is if you tell us. Now, you can do that by joining the WhatsApp community, and you can find a link in the show notes, or you can email us. And again, the email address is in the show notes. But unless you tell us what you'd like, we won't know. But we try very hard to make content, I believe, that is different to a lot of the content that's out there, and that in its way answers questions that we hear frequently in both of our roles, that we see online frequently, and that hopefully help you gain some insight and some information that perhaps you may have struggled to find had we not done that. So really, genuinely, folks, I hope it helps. But for now, that has been another episode of Talk ADHD, and we'll see you next week for another episode.